We're going to talk today about skin health and why it's important, as well as pressure injury prevention. There's been, especially in acute care, but long-term care, most areas are affected by pressure injury, but we see it more prevalent in long-term care and in acute care settings. So, why is it so important? What's the big deal about skin health? You guys?
It can cause a lot of things. It can cause infections, pain, just never-ending, really.
Mm-hmm.
We don't death, really.
Yeah, it can. Mortality rates, right? So I don't know if you guys are aware, but the interesting thing about skin is it's actually the largest organ. It's considered an organ, and it has a lot of functions, which we're going to go over. So we're going to talk about functions of the skin. We're going to talk about basic skincare, review of the products and their uses. I think sometimes we could all use a refresher on what's on formulary, how we use it, when we use it and when we don't. Okay, because like a lot of stuff in healthcare, we tend to start something and we just keep doing it and doing it and doing it without really thinking about what we're doing and why we're applying it and when we should be discontinuing. And then we're going to talk about all of our roles in pressure injury prevention. And I always say your guys' job is probably the most pivotal when it comes to skin health out of everyone on that team. You are the ones that are seeing their skin the most. You're the one who can be observing and communicating concerns. So it's really important that you guys are comfortable with what you're seeing and are supported in some of the prevention strategies that we could be doing, not just individually as a team. I also want to introduce the concept of involving the patient and their family members as a part of their role. And that's because when they come to acute care, ideally they don't stay in acute care. Eventually they're going to be going home or into care, right? So pressure injury prevention, skin health is on a continuum. So whether they're here in hospital or at home. So it's a great opportunity for you guys to learn and teach. Does that sit okay with all of you? Mm-hmm. Awesome. So let's talk about the skin. Like, what's the big deal? Why do we care so much about it? Just for simplistic sakes, we're just going to talk about the epidermis, which is the outer layer of your skin. The dermis layer, so that is made up of, there's oil glands and hair follicles. Your nerve endings are all in there. And then you have your hypodermis layer. So that's the layer where the subcutaneous tissue is, that nice cushiony layer that covers our bones and those kind of, all the organs underneath. And in that, that's where you have your vessels, okay, and your fat cells. And it's really important that we have a good understanding of that, because when that breaks down, we actually are increasing risk, right, for clients to become sick, either with infections, bacteria and such getting into bones and all the underlying structures in there. You'll have to forgive me, I've gotten getting over a cold. So, do you guys know what the function of skin is?
Part of the integumentary system is for protection, basically, keep us safe from biological atmosphere.
Absolutely, perfect, yeah. But it has a lot of other things it does too. So it protects us from UV rays, right? So we have stuff in our skin that helps us with that. It's a sensory organ, so touch, pain. It helps with regulating body temperature, so your hair and sweat glands help with regulating our temperature. And like you said, it acts as a barrier, protective layer. And it also helps keep moisture in. So our body is releasing moisture, and we don't want to shrivel up like a little raisin, so it has a nice little function that helps with that. Another important thing to kind of know is that our body is one big chemical reaction. And we have a pH, and our skin is a pH. And a pH kind of sits on a little bit of an acidic on the scale. So 7 on the scale of 1 to 9 is sitting kind of neutral. And we sit just below that, our skin. And then urine, which we're going to talk a little bit later about, is more alkaline, believe it or not. So it sits a little bit above that, so between 6 and 8. And it's important that we understand that, one, because of the reaction, the chemical reaction that can happen when urine sits against your skin, but also to know some of the products that we have and how it helps protect our skin from those things. So, protecting our skin. Why is it important to protect our skin?
Stay healthy.
Yeah, stay healthy. And there's many tools in our toolbox on what we can be doing on a day-to-day basis. Not in just the care that we provide, but even in what we teach our clients and our patients. So I work predominantly out of community, so I will refer to people as clients, just as I think in long-term care, is it residents?
Residents,
Or residents, yeah. And in Ty Watson House, we usually say clients or patients and hospital patients, but it's all the same. So as we age, what happens? What happens to our skin?
Wrinkles.
Not fun stuff.
Yeah, we get dry.
Gets thinner.
Gets thinner, that's right.
Yeah.
So we start losing that subcutaneous, nice cushioning, right? Have you ever seen like the elderly and their bum, they have less and less of a bum and more of sagging skin, right? Things like that. So because of that, think of all those things, you losing your sebaceous gland, those natural lubricating to our skin. We're losing fat cells. So we're more at risk for skin tears, injury like pressure injury, and those big dry, you take the socks off of an older person and it's Christmas all over
And it's
again.
snowing.
And it's snowing, yeah. So just think about those big chunks of layers of skin coming off, and then it's really opening them up to risk of bacteria and such getting inside their skin. And please feel free if you have questions or anything. Just shout them out. I think in the handouts, did you attach the skincare products? Perfect. So there's the skincare protocol, and we're going to go over each one. So in there, there's the instructions how to use it, why you use it, the indications for using it. So again, this is probably going to be more of a refresher for you guys. So basic skincare starts with cleansing the skin. So on formulary for Island Health, we've got a couple products for cleansing the skin. There's to be scent-free. They have a neutral pH and they're alcohol fragrance-free. So alcohol is very drying. You'll see it a lot in those nicely pretty scented lotions that we like to have. When we put them on and they put alcohol in there so it evaporates, so it seems like it's absorbing into your skin, but it's actually evaporating off those oils off of your skin and making you more susceptible to dryness. So guess what? You keep reapplying it because your skin's dry.
Yeah.
So when you're looking for creams, and we in home care, we teach this to the home care, the CHWs that work in home care, that a lot of clients, they should be providing their own lotions, but we should be teaching them to look for stuff that's either alcohol free, or if there is, that it's really low on the ingredient list. So the higher it up on the ingredient list, the more there is. So this is our no rinse cleanser, and it's the foam. Is everyone familiar with it? Yeah. And then this one is the shampoo and body wash. So it does have to be rinsed, and we have to make sure we rinse it really well off. This one you don't have to rinse off, this one you do. They can both be used all over the body and also on the hair if they need to.
You had an email a few months back saying that no rinse cleanser was only to be used for the hairy area. 6 months ago? something?
I've never heard that.
Yeah, I read it because they sent an email with the pictures of all of these and what they want us to use them for, and then they said that they just wanted that used for carrier.
The nice thing about this and using it for, especially for incontinence, is like if you're using something really soapy and you don't rinse it off, like if you're doing bed baths, right, and doing pericare, it's really hard to rinse this away without, you know, if you get a hose.
There's a lot of water.
It's a lot of waters,
Yeah.
and this actually has some conditioning in it, so you kind of know it's almost moisturizing for their skin as well.
I use it, it's just that email did go out.
Yeah, but it can be used everywhere.
Yeah.
Ideally, we get people in the shower to clean them. The other thing is that the elderly don't need a complete bath every single day.
No.
Why?
They don't sweat, they're not,
Exactly, like they're drier, so the more we put them in the water and expose them to those temperature changes and everything, it's like they're dry of their skin, they don't need it. So the other thing is not using super hot water, because that can really strip the skin as well. So using warm water, when you guys are providing care or doing showers and baths should be limited to 5 to 10 minutes. Not doing long soaks in the tub as much as they would love that. It's also really tough. So a really good learning for me is after like doing all this and teaching it is also when we apply our lotion. When we apply moisturizer after cleansing, we should be doing it with the skin still down. And I think a lot of times we work with people to dry them off really good and then put the moisturizer on. So the recommendation is after cleansing is that the moisturizer goes on within 3 minutes after patting them dry, so they're still down. Do you have any questions or concerns about or comments about the no rinse? No. So the next line of defense is our moisturizer. So this is, and I'd like everyone to sample it. Moisturizer should be used for dry skin or just to keep people moisturizing because we're doing preventative health, right? This isn't let's deal with it when we got the problem. Let's try and prevent. So we can be using this, they can be using it. So this can be applied anywhere, everywhere, right? Lower legs. So what happens if you have somebody with really friable skin, you know, the elderly, and it's like rice paper. You just feel like if you touch it, it's gonna like, you know, they want help out of bed and you almost don't even want to touch them because you think you're gonna peel their skin right off. Those individuals need this moisturizer at least twice a day. So someone like us or have minimally dry skin, once a day is great. But those when we're looking at preventing skin tears, we should be applying that moisturizer twice a day. Okay, so just as part of their skincare, basic skincare routine, morning and evening. Any questions or concerns about that? It helps decrease that itchiness too, so especially when we're concerned about them scratching, see that a lot in their legs, right? When they're in bed or they're sitting in the chair. And then we also have people that have issues with swelling, and that swelling causes itchiness. So if we can keep their legs moisturized, hopefully we can decrease the chance of them scratching and creating injury. Again, just the 3 minutes after cleansing while the skin is still down. So this next one here would be your next line. So this is a silicone based cream. And this is considered more of a barrier as opposed to a moisturizer. And do you know what the difference is?
Barrier will leave like a film.
Exactly. So moisturizers, we want it to absorb well. This is going to put a nice protective layer on top of your skin. So I want you to put that on. You put it on the back of your hand. And I want you just to feel the difference. So you felt the first one, right? Yep. Get you baby soft. Scratch your liver.
Yeah, when our skin get thin.
Yeah.
Well, mine is
Can you imagine I give you a skin tan? How rude. So you see the tackiness, how thick and tacky that is? Very different than when you're using a moisturizer. And here's the beauty of this. Like, this is considered on the same line as a barrier as Vaseline, right? And what it does is it creates a protective layer to help keep moisture in, okay? And also to prevent or protect from external elements, like
urine.
perfect, like urine, right? It's meant to be applied after every time we cleanse. So if you have someone who's got some incontinence, and they don't have skin breakdown or anything like that, maybe a little redness, maybe a little irritation, but nothing too bad, you're gonna go to this, okay? The other thing that it works really well with is decreasing that surface area friction. So do you feel how nice and smooth this
It
is?
actually really is.
So when you've got that on that frail skin on their buttocks, elbows, and those areas, it's gonna help decrease that stickiness of the fabric and everything going against them when you're moving in bed or them sliding around. So it kind of has a twofold with that as well. So it's to be used for mild incontinence-associated dermatitis. So just that really kind of pinky, irritated skin. Or you can use it for the treatment of dry, cracked skin. Those heels, you know, that are really dry, lower legs, elbows, fingertips. You can see that sometimes in some people when they get older. You can also use it for moderate to severe incontinence-associated dermatitis. So that's when things are getting a little bit more so. But what I find is that we end up moving on to the next product. Yes?
Sometimes when you shave a patient, resident, client, you'll see that they'll get a little bit of redness or their skin gets flaky in their face or sometimes in the beard line.
Mm-hmm.
So would you recommend the silicone one or would you recommend the one that provides the moisturizer?
I would probably provide them with the step one, the moisturizer.
Okay.
Yeah. Some of those people can also have like a bit of eczema
Yeah.
or psoriasis. So
Yeah.
you also have to be careful of what you're introducing because you don't want to create more irritation.
Right.
So I always start low and
Okay.
go slow. So
Okay.
again, with your face and the pores and stuff, you don't want to start blocking pores or anything like that. So
Right.
I would just start with this nice gentle
Okay.
moisturizer. I'm so soft, I can't stop. So our next one is called Extra Protective Cream. This one is also called EPC, and it's a zinc-based barrier cream. So the first one is that silicone dimethicone barrier cream. This one has zinc, and it's, I think, this one's 30%. Zinc. So really, zinc is really nice on the skin that's really irritated. This also has beads in it. Has everyone felt it? When you use it, how do you guys put it on?
So there's a debate for me. I was taught thin, but then I also hear slap it on, slather it on, so I
Not
don't
supposed to
know.
rub it in, right?
So when you use this, you're gonna put it on as thick so you don't see the skin underneath. So it's not thin, so you see through it, but it's not slathered on like you're, making yourself a big sandwich. It's meant to, so it's covering that red excoriated skin, right? You're protecting the skin from the stool and the urine. Okay, so if you put it on too thin, it's just gonna break through that barrier. So you want it thick enough, and it only goes in one direction. So if you have to apply more layer to it, you go in the same direction it was before. So you want it as thick so you don't actually see the skin underneath. So it's not like globbed on, and I've seen it. I've seen where It's
Yeah.
put on, and honestly, it is so thick in every crack and crevice, you can't get it off. So then what? So you start using it, you've talked to your team, and you're like, Mrs. Jones, her skin is like, you need to come assess this. It's really irritated. She's been, incontinent of stool and urine, and we're going to start using EPC. Then what? Clean her up. You put the EPC cream on, and then what? How long do you do it for? Every day till she's here?
Until she's better, like,
So how do you know she's better?
just observing the skin. When every time you clean it, you observe the skin, or redness, or blisters, or whatever.
Mm-hmm. Generally, what we want to do is every 3 days, you're going to remove all of it. In between that, when she's still incontinent, what you're doing is just cleaning off what's soiled and then reapplying in one direction. You don't have to take it right down so it's all disappeared. You're only taking off the soiled amount, okay? It needs to be soaked, so you would use your no rinse foam cleanser, and you're gonna leave it on there to soak it off. And a damp cloth, hold it there, right? And you're gonna gently remove it so the skin can be reassessed. So this should be in the treatment care plan. If EPC is started, there needs to be a date every 3 days for it to be removed completely so the skin can be reassessed. So you take it all away and it's just nicely pink. Then what? Do you put it back on again? So what would you do to protect them?
I'd use the fairy or the silicone.
Bing, bing, bing.
Yeah.
Yes, right. And that's the way it works, because what I see is the EPC, and this happens in community, it gets put on, and then it's on for the rest of their lives, whether they need it or not. The next thing we should be asking ourselves is, why are they incontinent? Were they incontinent before they came in, right? What's causing it? Should we need to kind of fix this before they go home, because we don't want them to be doing this when they go home. So another thing that, are you guys familiar with Drygo? Interdry? Interdry is another one, yes.
Yeah.
There's a thing behind you on the wall, you can like pull that off.
Thanks, I'm just soaking it right now. So Drygo is what is the next that we just redid contracts. Drygo is very similar to Interdry. So Interdry is, I call it a cool, the Cool Max material. Maybe I'm dating myself. Do they call it Cool Max still? The shirt fabric, that wicks, they're athletic or whatever.
Yeah.
So it's the same principle. So the difference between the two is Interdry is silver and Drygo is hydrogen peroxide. They both work the same way. They treat fungus, they treat areas of moisture by wicking that moisture away. Fungus, yeast, bacteria. The difference between the two, besides one being silver and the other one hydrogen peroxide, the Drygo is about 1/3 of the cost, which is huge, especially if people are having to buy this for themselves. They're both good for 5 days. They're both applied exactly the same way. You tuck it under the fold in a single layer with a 5 centimeter overhang, okay? Because that's what wicks everything away. The other difference is with Drygo, you can use creams and powders, where Interdry you cannot. It has to have contact with the skin. So one of the things I've been asked before is moisturizer or barrier in skin folds. I prefer them not to have that. You can use antifungal creams and powders, but what I find happens is when we're doing moisturizer in a moist area, we're creating more moisture. If there's yeast and we need creams, that's okay to put creams on, but what needs to happen is it's absorbed. So a lot of times what I see is we just put the cream on, the antifungal cream, and it's like, oh, less is more, right? Or more is even better. What we want is it absorbed all the way in, Okay, then you could apply the Interdry or the Dry Go. That's fine. I think, do you guys have it yet? Can't remember if
I
it's.
think we do, but I'll have to double check.
Okay.
Yeah.
Yeah, sometimes in community, all we use is a cotton shirt. We get them to put a clean cotton shirt on. Just anything to keep that skin on skin away from each other. So, some of what we were talking about, and you guys are familiar with, and I'm sure there's been a little bit of frustration with Steiners. How do you guys feel about these?
They're gone now, so I have no more feeling about them. Okay.
Are you sad?
I'm sad, yeah. But
Are you
that's how, I'm used to it though.
Yeah, and you're sad because it's just what you're used to?
Yeah, I think so.
Okay. And do you know what they're for?
Keep sheets
Well-
dry so we don't have to change the bed all the time.
Actually, you know what? You said that perfectly.
Okay.
They're to keep the sheets dry, right? What about the people on them?
Right, they probably don't keep the moisture off of them.
No.
And they're awful because they're thick and they level up.
Yeah, patients hate them.
So how much fluid do you think they can hold?
None.
Those green things?
Yeah.
Probably not much.
So-
I
Well,
think they
I've
can hold a
seen,
lot.
I've seen
Pardon?
liquid
I think
cooling
they can hold a
off.
lot.
How much?
How many cc's? I don't know, I'd say about,
Half
you
a
could.
liter.
I'd say maybe about 500.
So this is 500.
Okay.
Oh, gee.
You want to see what happens?
Let's
Yes,
go for it.
It's a
ma'am.
big mess.
Oh, now I have to. Okay, that's not even a third. Now the Ultrasorbs were developed to wick moisture and fluid away. They're disposable. They allow the skin to breathe underneath them. Bulky, not bulky, a little bit light. Now that's a lot of, like, that was double the amount that I put on here, okay? So when we're talking about good skin health, right, pressure injury prevention, what we're trying to do is a twofold: allow the skin to breathe and reduce the bulk and areas that can create friction, pressure areas, and things like that. When we're dealing with people that are having incontinence, or maybe they're just sweaty, they've come in, they've had a stroke, they're sweating, their temperature regulation is thrown off. This actually doesn't breathe. It holds heat in, right? Then we've got flannels, we've got bed linen. Sometimes, so we can keep the linen dry, we put one underneath the sheet, one on top. Heck, I know. Let's throw a diaper on them too. So they have a catheter in, but just in case, we're gonna put a diaper on them. Doesn't that feel good?
People are just tucked in there.
How much can this hold?
Probably quite a bit, I would think.
Probably the rest of that.
Yeah, I was gonna say at least the rest of that.
Okay, well, let's do that.
Chop it up, don't be shy.
Yeah.
Some heavy weather.
Well, I've seen some.
Well, you guys are doing such an amazing job keeping your patients and clients hydrated, because that's the other thing. They come in hospital, they get dehydrated.
Yeah.
Especially those that can't reach for the water themselves, and they're so vulnerable. They rely on you. They rely on you for nutrition. They rely on you for good skin health, especially those that can't get out of bed themselves, right? So, and I know, I had a grandmother in care, and it was really, really tough. Really, like, we worked short staff, and she couldn't have the luxury of just getting out of bed when she was thirsty. So, you know, and then she feels bad ringing, you know, I don't want to bother them, they're so busy. My
Right.
tongue is stuck to the roof of my mouth. So you guys have done an amazing job rehydrating. So I want you to come, I want you to feel this. Yeah. Yes, you do. You want to come and feel this.
We got gloves.
Sorry, Dallas.
It's water, it's not here.
I promise it's water. I filled it up from the tap.
Jeez,
That
Al.
holds a lot.
It does. It probably holds
But
more
how does that
even.
feel against your
It feels
skin?
nasty.
Yeah.
It's gross.
Actually, that doesn't feel bad.
Yeah.
Yeah.
And of all of it, I would want to be on this one.
Yeah.
I admit it. Yeah. Yeah.
And this has only been minutes since that's been sitting there, right? Now, I want you to think about my bladder's gone and I'm waiting for someone to change me. It's not going to happen immediately. We know that's not realistic. It's not going to happen. So I want you guys just to kind of take that away with you in the role that you have in promoting good skin health. And maybe there's some things that we can do to help our very busy job and our difficult job, but maybe there's some things that we can do to kind of improve things, and small changes, right? So one of those small changes we decided is let's try getting rid of these Steiner pads, okay? My next ask is gonna be, let's start getting rid of those briefs. Because I see it a lot. I see it a lot when I come in and I might do a consult on someone that has a coccyx ulcer and they've got a catheter in and they have a diaper on and they're on top of a Steiner, on top of a flannel, with 3 flannels on top of them twisted around them. And it's really, really difficult because we're creating tons of heat in there. And the question is why are we putting a brief on?
For me, I've found sometimes, especially with the elderly, they want to have underwear on. They feel naked without it, like they feel really uncomfortable. So
Nobody wants the birdie to fly away.
Yeah, that's right. So sometimes the last resort is kind of to get them to even be in a brief, because if they're not totally mobile, it's harder to change them and stuff, and they have their pants on and their underwear. So briefs are icky, but sometimes, and then sometimes you can go from there and get them out of the brief, but it's hard to like get them to not wear nothing because they feel really vulnerable even though they have blankets on.
So have you ever, do you ever, because I don't want to make assumptions that you do or you don't, when someone asks for a brief or you offer one, do you ask yourselves and you ask your patient, do you normally wear this at home?
I just explain to them what a brief can do because it doesn't allow them to breathe, but I don't ask them to wear them.
So what we want to do is either get them back to previous function or improve function. And so the worst thing we can do is put a brief on and promote incontinence. We're promoting it as opposed to promoting continence. Yeah.
Are you talking from a hospital setting or are you talking from a long-term care setting?
I'm talking right now in acute care.
Okay, that's fine.
Yeah.
Because if we were talking, and I don't mean to get off track,
Not at all.
I kind of agree with the young lady said down here about the brief in itself, and then when you start getting into behaviors, like I've seen an individual go through 2 mattresses because of his urine, right? And it was just because of his behavior, because he would strike out, and because you're in long-term care, it can be very tough to get in there. So the only thing that's kind of saving it, and for us able to do care sometimes, is go, hey, my brief was wet, can you come in and change me? But otherwise, an individual, he wouldn't have let us do care on him.
And you know what? I'm not saying there isn't a person or a place that it belongs on. I'm not saying that. It shouldn't be our first line. It shouldn't be our go-to for anyone coming in hospital. Again, always ask.
I agree.
Do you have incontinence beforehand? What is it? Some people, they have different issues. They might have a neurogenic bladder and they don't tolerate catheters, or there's many reasons why. But we shouldn't hasten it along. And then, you know, because it's easier to stick a diaper on somebody than it is to get them on a toileting schedule. So my request to you guys in this, and what the job that you do, and I know it's a busy job, but you guys have that front line, that first step in promoting this. So if they need an incontinent something, let's start here. Yeah.
Is this gonna be Island Health wide? Because it's not, I'm working in 2 different settings and every bag.
Everything takes that.
Yeah.
Well, in Vancouver on the mainland, a lot of this has been in place for.
And I just figured because, Island Health, we're all one.
We see in long-term care getting rid of the Steiner and going to the AV pad.
Mhm.
Well, they did at West Haven already,
Have they?
yeah, the Steiner's gone at West Haven.
Okay, I was just curious.
Yeah, I think what you're gonna start seeing is this kind of spreading a little bit more.
Sure.
And keep in mind, and that's why I ask, where do you guys all work? Because things might look a little bit different, but you guys are the advocates, right? And if you guys start seeing improvements, wouldn't that be nice to say, hey, we're the front runners here. This is what we're doing. Like you said, in Vancouver, Fraser Health, they got rid of Steiners and briefs. Huge cost to the system, huge savings, and to our landfill. And again, if we can be promoting continence, isn't that brilliant? So we're going to talk a little bit about unrelieved pressure. So what is it? What causes pressure injury?
Sitting in one spot for a long time.
Pardon?
Sitting in one spot for a long time.
No.
Yeah, could you imagine if I said to you guys right now, none of you for the next 15 minutes are allowed to change your position.
I've
Whatever
done that.
you're in, yeah, there. You have to stay there.
It's
So
awful.
we also have the luxury and the ability to shift when we're uncomfortable, right? Numb bum, who doesn't lift a cheek cup when we get a little
I
bit.
haven't sat still since I sat down.
Yeah. So think about those people, have had CVAs, paraplegic, quadriplegics, someone that has come in, they're weak. They rely on you guys to shift them, to check their skin. They might not have the sensory or the strength to do it. So what happens is, remember when we looked at that section of the skin? You had your epidermis and that dermal layer, and then below that subcutaneous fat, and guess what? Below that is the bone. And that bone is creating pressure, intrinsic pressure on the inside. But whatever surface they're on is creating pressure on the outside. And what that does, because remember in here, this is where all the blood vessels are, it gets squeezed. And so if we have over time are sitting and squeezing, so you have someone who's fallen at home and they can't get up. We don't know how long they've been down for. They come into a merge. They sit on a stretcher in a merge for who knows. Then they get admitted. They come to med-surg. They get transferred from the stretcher to the bed. And they're in the bed for who knows how long. But maybe it's in that same spot. So, the next slide, we're going to talk a little bit about that. As much as you could get pressure injury from a mattress, think about what would happen if you were lying on the ground. I'll never forget this gentleman who came in. This was a long time ago. He collapsed, but he was actually pinned between his couch and the wall. So he had pressure injuries on his back, on his front, on his head, on his face. He was just covered. And it was just devastating and painful, and he had a long road to recovery. On top of, he had a stroke, so there was weakness in there, so we were constantly doing skin checks. The other thing I want you guys to be mindful of too is equipment. So equipment can create pressure injury. Catheter tubing, IV tubing, NG tubes, anything that is underneath pressure, your body, the weight. So think about that when we're repositioning it, where catheter tubing is it underneath? I've even seen the little tiny IV cannulas when they're doing IV starts or butterflies, the little safety things, stuck all over somebody that was left in the bed. So just that kind of looking at how the sheets are, anything underneath. Again, trying to get rid of bulk.
So if we know somebody's incontinent.
Yeah, that's different.
Okay,
If someone comes in, you're not going to be like,
Okay.
you are not getting.
I'm just making sure.
Yeah, because I
We
saw
wanna
something
change
last
sheets
week, a
and
fella
outside.
with some C. diff, and they were, after they had their course, they didn't put a brief on this fella, or a pull-up, he needed a pull-up, and we were cleaning C. diff from one end of the room to the other, and I'm like, that is one extreme to the next.
Yeah. And so we have to use a little bit of common sense.
That's what I was thinking.
My first and foremost, and I get it comes so quickly, right? Especially with C. diff. It's like, it's coming out of them before they can even
Right.
ring the bell.
Right.
But that's the person that you want to make really good skin protection
Yeah.
on, and they're not sitting in that brief.
Right.
Because guess what? That stool is corrosive. What is in that stool? Digestive enzymes.
It's just nasty.
That is going to erode, and especially if they're incontinent of urine, it's just going to melt their skin away.
Yeah.
So if you know they have C. diff, you're going to be doing a lot more checks on them.
Oh, absolutely.
Again, hopefully it's short term, and then you can get them out of the brief and onto a toileting schedule, any of those kind of things. So, like I said, it's not, there are times where you definitely need a protective, but this is not going to protect their skin. It's just going to help contain. It's still sitting against them. Nice and hot. It's really good.
For a little while.
So, how long do you think it takes for a pressure injury to develop?
Oh, not very long.
So this is considered a stage 1. This is the back of a heel. How long do you think that took?
Couple hours?
30 minutes, 2 minutes, 2 hours, 8 hours?
I think a couple hours.
Not very long.
Not very long at all, no.
The minute blood flow stops.
A couple hours.
So
Yeah.
how long? Couple
Yeah, I'd
hours?
go a couple hours.
Yeah.
So if a patient is exposed to unrelieved pressure, and this is what causes, it's unrelieved pressure, their underlying tissues such as the skin, soft tissue, muscle, and bone are creating that, there's that internal and external force causing that pressure, right? So, 30 minutes of unrelieved
Holy.
pressure. You were gonna have redness, that's the hyperemia, so that kind of stage 1. When you start seeing that deeper dark red within 2 hours, this is unrelieved pressure. Tissue ischemia, so that's, you're starting to get cellular death, 2 to 6 hours, and full tissue death is 6+ hours. And that's why I want you guys to be thinking about, hey, this person was at home on the ground. Think about, now they've been in a merge, and now you've got this really important job. You're gonna be the skin checker, right? You're gonna be like, hey, how long was this person down for? We're gonna have to check their heels, their backside, their everything, right? And then you're gonna be communicating that. And it's really important that a merge is making that communication to the med-surg staff, because you guys are gonna get on it, right? We're gonna get them on a turning schedule, you're gonna be doing skin checks, and you can be preventing a lot of further damage.
What causes skin, like when you get down to a pressure off, it starts to tunnel? I've seen a few of those. What causes the tunneling?
Unrelieved pressure, and then you have that necrosis, so that
Right.
cell death, then all that tissue's dead. When that tissue dies, it's a breeding ground for bacteria.
Oh, okay.
And that's what will happen, it just, the bacteria just starts
Oh, okay.
festering through. And then you have someone with incontinence.
Oh my
It
God.
gets the stool,
That's just
that
so
E. coli is
bad.
getting in there, so there's a lot of nasties that
Right.
make sure guys' job like that much busier, right?
I was in New Carey when I saw an opening wound like that, and she was highly incontinent, and it was just horrifying.
So some of the things that we also have to keep in mind when we're thinking about pressure injury prevention and decreasing it from getting worse or helping to improve it, because the only way to cure a pressure injury is what?
Offload.
Offload. Get them off of it, right? And sometimes it doesn't mean they have to be right over onto their side every time. So I'm thinking about heels and coccyx, right? Because those are probably the most prevalent scapulas. Most of the people, how many of them are like, can I just lie on my side? Like most people want to be on their back,
Yeah.
right? Have you guys ever lied in the bed, just lied there and let the head of the bed go up? You guys need to do it. It's horrible. It's like you're just like sandwiched and stuck in there. So what we need to start thinking about is lifting them away as they come back up. So if they can't do it themselves, getting underneath their shoulders and lifting them away, because there's going to be shearing and friction when that goes up. Their skin's going one way in here. So as they go up, the skin gets pulled down as the bed's coming up. So what we want to do is lift them and then back again. And it gets their bum and their back kind of out of that hole. The other thing I want to talk about just real briefly is the length of time you're on a surface. So we have that, you're down for 30 minutes or 4 hours or whatever it's going to be. I want you to start thinking about, you know, the mattresses. So we have pressure relieving mattresses, offloading mattresses, Roho cushions. So those are gonna help decrease some of that surface area, right? It redistributes those pressure areas, those bony prominences. But you also have to think about nutrition status. So how many of these people coming into hospital are like malnourished, underhydrated, right? And this is a team approach. It's not just you guys. And when I'm saying you guys, I'm talking about the healthcare, the team, right? It's a team. And the best part of that team is the communication. So you guys are the eyes, you really are. And you do an amazing job in this, in their skin health. So, and I know the jobs are busy. We need more and more of you. And unfortunately, we don't always have it, but. So how often are we doing skin checks?
I look at the skin every time I dress them, undress them, change them, wash them. I'm always looking.
Everywhere?
Even when they're sitting, yeah, wherever.
In the
yeah.
handout, there should be, there's a great little handout, and it's actually for families and patients. That's on the last one, but one of them is also a photo of the high incident areas of pressure injury. And I think, are they posted yet at the head of the bed?
Yeah.
So they're posted at the head of perfect for us, yeah, as that kind of visual cue of some of those areas that we should be checking. Someone who's on long-term oxygen, you know, the oxygen behind their ear, we need to be checking their ears, right? Again, so that is an area, so that's a mechanical pressure injury if something's sitting there on them. But how often should we be checking? As often as you can, great.
Well, I'm looking, every time I'm looking at them, I'm checking.
At least every 2 hours, shifting position every 2 hours for someone at minimum. Yeah. And what does it look like to offload heels when someone's in the bed or in a chair or something? What does that look like to you guys? And actually,
off the bed.
heels off the bed.
Yeah.
And this is actually
Floating in the air,
especially
basically.
Important in emerge, actually, because it's one of the people who are in there for a long time. Things get busy, and that's why I'm so excited that you guys are there to kind of be able to be that, those eyes on them. Because nurses, we get so on one thing, right? And we can't think about that, but it starts there for sure. All you have to be able to do is put a piece of paper underneath, right? They don't have to be way up in the air. And not on a pillow. So we see like, oh yeah, I took them off the mattress, but I rested them on a pillow. It's just like putting them on a mattress again. So they need to be floating, okay? Does that make sense? So depending on an individual, if they can do even small amounts of shifting, you can decrease them to every 3 to 4 hours. And then getting them up, getting them moving as best we can. We talked about the pressure relieving mattresses. And again, I think we talked a little bit about that pressure injury prevention, right? What the beds look like, the hospital bed. I really do invite you guys to lie in one of the beds and put them up. Dogs, maybe you can do that. And I want you guys to not move. I want you to lie there and let
Great job
the
on
bed
one of the
do it.
videos doing that
And you gotta
too,
think,
showing the
a lot of people
demonstration.
have their gowns, so it's bare skin where we're still gonna have our clothes on.
Yeah, it's, I think when you start feeling the things that we're doing and doing the things that we're requesting or doing with our patients and clients, I think it helps you kind of go, oh yeah. Like even flipping a pillow. You know when you're in bed sleeping at night, it gets so hot, you flip, it's like, oh yeah. Things like that can just make such a big difference. So communication. Jamie. How do you guys communicate with your team?
I wanted to pull it up on here, but I didn't
Okay.
pass it to her.
Want me to pull it up?
Well, what else? Do you want to do the case study though?
Yeah, we can do a case.
Or do you
Do
want
we
me-
have time?
Well, if you guys are finding like red marks on skin and stuff, how are you communicating it right now? Like in your documentation? and
I'm
stuff?
putting in annotations, verbally talking to the nurse, because they'll be staying on longer and they'll relay it to the team that's coming on. But usually it's annotations.
Okay. have you guys seen on your documentation the skin checklist? Yeah, and has any of you used it?
Cattle River bid AC turn.
Oh, because they're still on paper?
Yeah.
Yeah, okay. So I
Not even
would
included
invite
in
you just
SDR.
to take a look at this, and I'll pass it around. And what it is
Here's
it's
the next.
on your documentation right here. And it actually says skin checklist. And basically they're yes or no. So what you can do is yes or no and add a comment. And then it will show up on your patient summary page, and then you can do your carry to nurse notifications. Yeah, I don't know, did you know that was there? No.
I never, honestly, I just felt all of that was like a nurse documentation, and I felt that if I saw that, I would like tell the nurse, but I didn't realize that I should actually document it.
Yeah, so, sorry,
I
I
missed it.
don't know if we can pull it up on there, but it's kind of hard to see in here. So, if you guys just want to gather around here, this is your documentation right here, basic hair documentation. So on here's your skin checklist.
Yep.
Okay? Skin checklist is here, so it has skin tears, scratches, reddened areas, broken, open areas, black color, dry skin,
Okay.
new bruising, swelling eyes. The only thing you can answer in here is yes or no, okay, which
Okay.
doesn't give you a lot, but you can certainly add a comment. But what I would really invite you to do, and it is on this your patient summary page, you can move these around, right? So you can put your skin checklist and carry to nurse notification right at the top. So when somebody's looking at this, they can see what you've answered and then what you've told the nurse and what you want them to assess. So as carried, you guys can make observations, right? But you can't actually assess. So you're asking the nurse to assess, it's documented, and then the next carry can follow up with it. So it's just another way to track it, right? Or if they've had the EPC cream on for 3 days, now it's ready to come off and be assessed, you can write it in here.
Huh, well, good to know.
That's good information.
I know you're not electronic yet, but when you're
Oh, I still
here.
use power chart up there.
Oh, yeah.
I can't read that.
Okay.
I have to know everything
Yeah,
about
so
them.
if you guys ever need help with finding this, I'm always around and I can certainly help you when you get to it and you're not sure how to do that. But I think this will be really helpful for communication between all of you and to the nurse as well. And this doesn't actually notify the nurse. This is just a legal documentation of it, but you have to verbally tell the nurse, please go and assess this area. And it's a way for just to follow up and stuff. Yeah.
So I just want to do a quick case study because they're fun.
Oh boy, what do you got up there?
So this is an 80-year-old gentleman that was found at home by his daughter, laying on the ground for an undetermined time. He was incontinent of stool and urine. His wife was home at the time. She's severely demented. He was admitted to med-surg with diagnosis of a CVA and right-sided deficit. So, what do you guys see?
Pain. Lots of pain.
Yeah, poor guy. He did have a lot of pain.
That looks bad.
We had a guy in Cattle River Hospital exactly like this. He lay in his feces for 4 days.
Oh, Lord mercy.
Yeah, it's like throwing battery acid on
Yeah.
him. Yeah, absolutely.
Yeah, it looks burnt.
Yes, it is. So you
Yeah.
do treat it almost like a burn. So after really good cleansing, so we would use your no rinse, right? Nice and gentle. I still use a wet cloth with it, just to kind of remove any of the soil or whatever. Now what are you gonna do? So you've done that. And we've determined he's got severe, moderate to severe incontinence-associated dermatitis. He also has, do you guys know what these are? Where he's fallen at home. What else did we learn about today?
They look, it kind of looks like a pressure sore.
They are, they're pressure sores.
Okay.
So pressure ulcers, right?
Okay.
These are over areas of boniness. So that's his ischial tuberosity
Oh,
here.
yeah.
This is kind of the side of his hip. And up here is at the iliac crest. So that's where he was sitting. And
Wow.
so we're gonna kind of do an application very differently than just with the incontinence, right? So we wanna still protect his skin from that incontinence. So at this point, he's probably going right to what? What would you grab off the table?
For the wounds themselves or around the area?
So around the wounds, you guys are gonna be applying
Probably, yeah,
the
that's that one.
EPC.
Yeah.
So this is gonna get applied everywhere around here, right where you have that red excoriated skin, right down into the gluteal fold, up and towards the scrotum, because that was actually burnt all up in there as well. In how many different ways you're gonna rub it in?
No, one way.
One way.
Yeah.
And how thick?
So you can't see it.
Till
So
you
you can't see
it,
it.
but
Just
not
enough
block.
so you can't see it.
Yeah.
Do you guys know what this is?
Yeah.
Try it. And what's it used for?
Open areas?
It's almost like I've been told it's like a
It's like a
artificial skin.
Miracle cream.
Liquid Band-Aid is what I call it.
So yes, no, no, no.
Okay.
It's not a miracle cream.
No.
It's not even a cream. This is called, it is a zinc-based ointment, but it's a hydrophilic dressing. It's like putting a dressing on a wound.
Right.
This is not to be used for incontinence,
No.
okay? And I see that used a lot. It should not be used as a moisturizer. It's put on in one direction up to about, I think it's a 3 millimeter thickness, so enough so you can't see it. After it actually adheres to the wound, it creates a protective, so they're meant for shallow wounds, so something like this. Because it's difficult to put a bandage over top, you could use something like that. And we want to be keeping him off his backside, right? Because he's got pressure injury. We don't want to have diapers on him. We want air to get at the area. But I see this used improperly. So this can be used on the actual pressure area, and this would be used all around the skin to protect, okay? So they're not interchangeable. This shouldn't be used over the pressure injury, and this shouldn't be used over an incontinent broken skin.
Question.
Yes.
I've seen this a lot where the EPC is mixed with a
Don't.
moisturizer and then applied.
You're negating its effects.
Okay.
Yeah, and that's not the intended use.
Okay.
And what's the rationale behind it? So it goes on easier, so it's not as sticky, because people are
Okay.
wanting to put it on like this, and they see that it sticks to the skin, and you can actually pull skin off. Same with the triad. It's soaked off, you don't rub it off, or it'll absorb into the wound itself because of the drainage. It's not meant to be rubbed on, and it's not meant to be rubbed off. Okay, so that's, I think, why people will mix it with the barrier cream, but they counteract it. So
Good to know.
I say no.
Okay, thank you.
You can say no too. How was that?
Good.
Helpful?